Well, good afternoon, everyone. I'm sorry for our technical difficulties, but I'm thrilled that so many of you have chosen to join us on this Veterans Day holiday. My name is Tracy Moorhead. I'm President and CEO of the Care Continuum Alliance. We are a trade association representing the population health management industry, and we are also a member of the PCPCC, and I serve on the executive committee. And I'm also participating with the Center for eHealth Implementation and Adoption on some of the work that they're doing. I'm quite honored to be here today to present some of the work that the Care Continuum Alliance has undertaken to tie together the concepts of population health management and the components of a population health management program with some of the key health information technologies that drive those various components. I'm going to spend some time outlining our population health management framework so you understand what it is we mean when we talk about population health management, how we've defined it, and outlined the core components of a PHM program. And then I'm going to tie that into the framework that we've recently published for the health information technologies that drive each part of the component. And then we'll stop midway through and take some questions as well, and then questions at the end in addition. If you have questions, there is a question box on the right-hand side of your screen, and you can type your questions into the box. We can choose to answer questions during the presentation, or we can hold them until certain parts, depending on how we see the questions coming up. So do feel free to put your questions in the question box if you have one while I'm giving the presentation. This slide is a representation of the expansion of interventions that we now call population health management. Originally, such interventions were really focused on those segments of the population that had already been identified as having a chronic illness or multiple chronic illnesses. This evolution of our interventions has really expanded dramatically in the last 8 years to include not only those who are at risk for chronic conditions based on their health status, but also those who are healthy, but to help them understand how to stay healthy and to make healthy choices for the longer term so that they don't develop risk factors and eventually develop chronic conditions. This is the full spectrum of population interventions that our industry, the population health management industry, now provides. I might also add that many of our members of the population health management community and of the Care Continuum Alliance specifically are also very involved with the PCPCC and, frankly, are supporting patient-centered medical homes to provide many of the interventions necessary to manage chronically ill and at-risk populations, including providing wellness programs for the healthy and the at-risk segments of those populations. We established a definition of population health management 2 years ago, actually, and as I've mentioned, it encompasses a much broader approach than typical chronic care management, wellness, or case management programs. Our definition is that a population health management program addresses the health needs of a population at all points along the continuum of health, as we've just demonstrated in the prior slide, health and well-being through participation, engagement, and targeted interventions for that population, with the goal of the program being to maintain or improve the physical and psychosocial well-being of individuals through cost-effective and tailored health solutions. I want to specify that there are 3 core principles to a population health management program as we have defined it. I'm sorry, the slides seem to be very slow. There we go. These are the core components that we have identified that are necessary for the success of a population health management program. One is the central leadership role of the physician, whether it is a primary care physician or another leader of the medical team. This is very important in establishing the plan of care and coordinating the plan of care across multiple sites and providers. The second important component is the activated, engaged, and educated patient or consumer, providing the resources necessary to help the patient understand, to empower the patient to take control, and to activate the patient to move forward with the plan of care in the way that the physician has prescribed. And finally, the third key component of a successful population health management program is really the capacity expansion achievable through the care coordination provided by non-physician team members, whether it's a health coach, a diabetes educator, a nurse practitioner, a dietitian, a licensed clinical social worker, etc. There are a number of non-physician team members that support both the consumer, patient, and the physician in achieving optimal health and well-being of individuals in a population. We have developed two models that I want to share with you today. One is our conceptual model, and one is a process framework for population health management. The frameworks illustrate, again, both conceptually and operationally, population health management programs. And they have their origins in the previously outlined definition of a population health management program that I recently walked through. These frameworks have been developed as a guide for care delivery models seeking to integrate and implement population health management programs and processes. For example, care delivery models such as integrated delivery systems and most likely accountable care organizations, as well as primary care providers and patient-centered medical home practices, can adopt these processes and the key components that I'm going to outline in these frameworks to assess their own capabilities and to guide the development of expanded and integrated care delivery models. Our work to develop the conceptual and operational frameworks repeatedly drew attention to the expanded use of a variety of health information technologies and the recognition of these technologies as a requirement for really fully operationalized population health management programs. So that the bulk of this presentation will be to outline these complementary health information technologies and the framework that we've identified for both information and technology components to help all delivery models understand the components necessary to deliver a comprehensive program focused on population health. So this next slide is the conceptual population health management framework. And the intent of this model is to complement the more detailed process framework that I'll show on the next slide. This identifies the general components and stakeholders of population health. And like the more detailed process framework that I'll show next, this conceptual model depicts the identification, the assessment, and stratification of program participants. However, the core of the model, represented in the central blue box, and surrounded by the overlapping sources of influence, is surrounded by, the core of the model, which is in the big box, includes the continuum of care as well as health management interventions. The patient or consumer is central in the model and is surrounded by the various overlapping sources of influence on the management of his or her health, as you can see here, whether it's cultural or tailored interventions or community resources. Operational measures are represented under program outcomes, as are the core outcome domains from our population health management process framework. Finally, the cycle of program improvement based on process learnings and outcomes is prominently depicted by the arrows that curve back up to start the framework again as individuals continue to manage their care across settings and throughout the progression or mitigation of risk factors. This next slide is the process framework that I mentioned. I can get it to come up. There we go. I recognize that this is a very difficult slide to see on a screen like this. This is an updated process framework that we have developed. And it's intended to help improve the understanding of the essential elements of a population health management program and how they relate to one another. It outlines the process flow associated with operating a population health management program, beginning at the top with monitoring the population and identifying individuals for a specific program or intervention. It also includes an assessment stage, followed by risk stratification, the application of enrollment and engagement strategies to get people engaged and involved, the availability of multiple communication and delivery modalities, health management interventions that span the care continuum, and program outcomes across multiple domains. And finally, it includes also here the feedback loop that reflects the need to incorporate process and program improvements based on learnings from both operational measures and program outcomes. And it's been very clear to the population health management industry that that not only will these types of process components continue to evolve as we learn more about the science of intervening and behavior change and activation, but that also the supporting technologies for each of these process components will evolve. And so we do fully expect this process framework will continue to evolve in coming years. So before I turn to the health information technology components that are the focus of our presentation today, I wanted to stop here and ask if there were any questions about the process framework or the conceptual framework that I've just outlined for population health management programs. Again, feel free to type any questions that you might have into the box if you have any questions.
And Tracy, I'll just use this opportunity to jump in and see if our technical difficulties have been resolved. I don't know if you guys can hear me or not.
Yes.
All right.
Welcome. Would you like to say anything?
Well, we can do that. That actually was pretty funny. I'm not sure what happened there while we're waiting to see if we have some questions. I'm not sure what happened there on the front end because everything was showing me as fully unmuted, but suddenly nobody could hear me. So, and what we'll do is we can take care of our housekeeping stuff at the back end.
Okay. Great. Okay. So, as I'm sure you're aware, population health management relies increasingly on data-driven and HIT-supported interventions. And as you're well aware, there are numerous federal government initiatives underway to expand the adoption and implementation of these health information technologies. Appropriately, many of these initiatives are focusing on establishing standards, defining effective use, and measuring quality improvement that can be achieved via the application of health information technologies. And as these technologies continue to evolve, so will the ability to enhance health consumers' experience and to enable communications and information sharing across all care settings and providers of care. Recognizing this, Care Continuum Alliance last year endeavored to develop a better framework or a landscape, if you will, to help folks understand the key areas and core competencies of health information technology utilized in population health management programs. To identify both the key components of health information and health technology that are necessary to fully operationalize population health management programs. This was a joint project undertaken by our Health Information Technology Committee, which is chaired by Dr. Joseph Kaviter from Partners Healthcare in Boston, and also our Outcomes Work Group. And our Outcomes Work Group has been working for 5 years now with over 200 individuals and companies and partners to develop outcomes measures and evaluation methodologies for not only chronic care management and wellness programs, but broader spectrum population health management. These two committees work together to begin to discuss the roles of health information technology and how they fit into various parts of that process framework that I just walked through. It was immediately understood that these technologies necessary to fully operationalize population health management programs extend far beyond electronic medical records and encompass a very wide spectrum of innovative technological devices and applications. And as such, the HIT framework that we have now developed is intended to complement and expand upon the conceptual framework by first identifying some of the uppermost levels of data exchange, particularly as envisioned by the HITECH Act, and then coming down through from those broad levels of data exchange all the way down to the types of devices that enable consumers to better manage their health and to engage and activate those consumers in management of their own health. So that's really the background on developing this framework. Let me see if I can get to the framework. Here we go. So this is the core of the framework that we have developed. And let me quickly just go through and get in here the examples. And these examples are not intended to be all-inclusive. They are a little problem here. They are simply examples of some of the technologies that might fit into each one of these bubbles. Let me start at the outermost bubble and then work our way down through the HIT framework here. So you'll see that the outermost bubble is at a dotted line. And that's because we do see this as evolving rather quickly, given what's going on with the health information exchanges, the RIOs, and the likely development of the ACOs, the shared saving regulations and programs that we're expecting very soon. This regional, what we're calling regional data liquidity, really circles the entire framework and refers to regional data hubs that are envisioned to compile and distribute data for an entire population that exists within a specific geographic region. We're envisioning that this data can be collected from a variety of health delivery sources, including hospitals and providers, as well as non-traditional sources such as community centers and public health agencies. An example represented here of these high-level data hubs are envisioned as the accountable care organizations, health information exchanges, and the RIOs. And again, this is at the broadest level for the beginning of the impact of health information technologies on population health management. The next part of the framework, moving down, is really the systems and person-level databases. And this component refers to the databases and systems that are used to identify, assess, stratify, and enroll segments of a population into specific programs. Both systems and databases, as envisioned here, enable the assessment, stratification, and engagement process as identified in the earlier process framework that we referenced, and as well as the ability to measure the program outcomes. And I might see if this will work. There we go. So jumping to the framework, if this works, we have identified the core components of the process framework that we believe are impacted by these person and systems level databases that I just referenced. So the technologies represented here, including electronic health records, labs and claims processing databases and systems, are those technologies or information technology that can help to drive and influence the success of each of these components highlighted here in yellow as part of the PHM process framework. Next on the framework is the infrastructure and services component. And this is the third component of our framework and is focused on information and technology needed to support health providers in their efforts to enhance the services they provide to patients or consumers. This infrastructure, combined with the complementary services, enables the enrollment and engagement process as well as the process of communication and intervention delivery. Examples that we've included here of infrastructure and services include rules engines, decision support tools, and intervention-level databases such as practice panel patient registries. And again, as referenced, we believe this will help influence and drive the success of these segments of the population health management process framework to enroll and engage, to communicate and intervene through various delivery modalities, and specifically health management interventions. The next component of the framework is focused on devices, devices that allow and enhance communication between and among healthcare providers and healthcare consumers or patients. These devices enhance the ability for providers and consumers to exchange and share information and contribute to most of the processes outlined in the population health management process framework, including enrolling and engaging consumers and patients, program delivery and outcomes measurement, communications and intervention delivery modalities, and also health management interventions. And again, examples that we've identified, and again, this is not an exhaustive list, include home health hubs, personal health records that enable an individual, a consumer, or a patient to develop their own online health database, and also monitoring devices that a healthcare provider may place in a home of an individual so that they can report their weight or their blood pressure, or in other ways connect and provide information back to their healthcare providers. Finally, we have end-user medical devices, and this is, I think, one of the most exciting and fastest growing components of the health information technologies that we identified in driving the success of population health management intervention. This component of the framework includes devices used by healthcare consumers to communicate and exchange information with healthcare providers, but also among a variety of healthcare providers, not just their physicians, but some of the other non-physician practitioners who may be helping to manage their care. These devices contribute to the process of successfully communicating and delivering program components, and also to the health management interventions, as I referenced. Advancements in this area of the framework have really produced a variety of devices and repurposed, if you will, some devices, including cell phones, that are now rapidly becoming a very important part of population health management interventions to help individuals communicate with their providers, but also to help those individuals better manage their own care. So this is the framework that we have developed, again, for health information technology to link back to the population health management process framework. We're very excited about this, and we're going to continue to evolve this framework. We have been using components of this framework to talk with the HHS Health Information Technology Policy Committee as they work to develop the Stage 2 meaningful use criteria, and there's been a lot of interest in the way we have linked this back to population health management interventions. I should also stress that this is something that we believe both the population health management framework but also the health information technology framework fits within a variety of healthcare delivery models, whether it is a patient-centered medical home or an integrated delivery system, or as we understand the definition at this point, given that there are so many, an accountable care organization. That the process of population health management contains the same components, regardless of which type of delivery system. You may have different people combining to provide different aspects of those components, but they're going to need many of these technologies to drive those components in order to achieve successful health outcomes, improved quality of care, and reduced costs across the board for healthcare, for specific populations and for populations as a whole. And so I hope that this is something of interest to you, and I see that we do have some questions, so I will turn it back over to John now to let him moderate the Q&A section.
Great. So just taking a quick look here at questions, and I'm sorry, but okay. So first question up here is sort of a general question around who's managing the population. So I think that if I interpret that, it's from the perspective of sort of who is it that's, or what perspective are we looking at this from? In other words, are we looking at it from a PCP perspective or from a broader perspective? And I thought there was more to that question, but I'm trying to pull it up, and more technical difficulties here.
Yeah, I'm having a hard time seeing the questions as well.
Yeah, the problem is I'm seeing about half a question at a time, which is really tough. But anyway, so maybe let's just tackle sort of as you think about population health management. Who are you thinking about it as sort of the overall manager of population health management that we're addressing here?
Well, the overall manager of population health management is going to be the physician, who is going to be managing the team that provides the services to achieve the ideal well-being and health status outcomes. You know, that team can vary dramatically based on the type of practice, the patient panel involved with that practice, and the needs of the individual patient. Again, going back to our original definition and core principles of population health management, the physician being the team leader, but the team shifting based on the needs of that patient panel or population. And so those folks who are providing day-to-day care, guidance, and coaching to the individual might include non-physician practitioners such as licensed clinical social workers, dietitians, case managers, diabetes educators, etc.
Okay, so I think a very broad sort of framework in terms of thinking about a lot of people ultimately that have to touch population health.
Yeah.
There was not sure whether it was a comment or a question. Somebody said define RIO. That might be a suggestion that it would be a good idea to define what you mean by RIO, or maybe it was actually a question, but maybe you want to just do that one real quick.
Well, the RIO are the Regional Health Information Organizations, and many of them are currently still under development, but they were envisioned to provide this data liquidity at a regional level to provide physicians and other practitioners the ability to better manage care and better measure outcomes. Still having a hard time seeing the question.
You know what I discovered is actually you can, if you grab the chat bar, you can pull it out. You can tell we don't do enough of these webinars. But if you grab the right where it says chat and pull it out to the middle, you can then grab the bottom of it and expand it and see the whole question list, or at least a much bigger chunk of the question list. There's another question here. Basically, population health management is sounding like the patient-centered medical home. Is this true? Let me just offer a quick thought from my end, and then see if we're on the same page here, Tracy. My quick thought on that is that population health management is one key activity that the patient-centered medical home needs to engage in, and it's critical in the sense that it's something that most primary care physicians have not historically done. So it's a new activity or a sort of new MO for a typical primary care practice. So my thought would be that population health management is not equivalent to the patient-centered medical home, but is a critical activity within the patient-centered medical home. Would you say that that makes sense, Tracy?
I would say that we're very much on the same page. I think that whether you're looking at a patient-centered medical home or what we've identified as the likely components of an accountable care organization, there are other aspects of those models that population health management does not address. And some of those are infrastructure and governance related. Some of those are payment related. But if we're talking about care coordination and we're talking about health management, then I think that the core components of population health management fit very well within the care models defined as patient-centered medical homes or accountable care organizations.
About the question here, can you comment on e-health, by which I assume the questioner means HIT, Health Information Technology, as a patient activation tool?
Well, I think that's a great question. And, as we've referenced on this framework, particularly in the end-user medical devices and the communication-enabling devices, the expansion of devices available to consumers that consumers feel comfortable using. And I use the cell phone as a primary example in this case, that really consumers are comfortable with, that they are appreciating, for example, text messages, the ability to text message their doctor or another member of their healthcare team. This is a very rapidly growing and important aspect of population health management and e-health, as you say, that is really having a great impact on consumer engagement in taking control of their health, activating them to do so, and empowering them, giving the empowerment that they feel is necessary to go ahead and do that. And I think that those end-user medical devices are really going to be crucial in further improving health status of populations.
And let me also just apropos of that question, put in a plug for the recent PCPCC publication. If you take a look at the Collaborative's homepage, you'll see there's actually two recent publications. One is a white paper around decision support, and the other is a resource guide that is, in fact, focused on health IT as a tool for patient engagement. Now, I'll tell you that in that resource guide, we looked more than just at patient activation. We looked at patient engagement quite broadly, and in fact, we took a sort of a perspective that patient engagement is actually a two-way street. It's not just patients being engaged in their care, but it's also how the care team engages with the patient.
Right.
And so the stuff that's covered is, sort of goes beyond just the issue of patient self-activation for, chronic management or general wellness. But there's a lot of really good stuff there. So for anybody who's looking for more on health IT and patient activation and engagement, just check out it's freely downloadable. You can get it right off the PCPCC website.
Great.
Let's see. Another question is, and this is sort of the really tough one, I think, all the time, but how are physicians going to be paid for these kinds of services? You want to give us your crystal ball on where reimbursement is going?
Well, we're very excited. First of all, my crystal ball is just as cloudy as everyone else's on this. We're very excited about the shared savings programs that HHS will be developing, because we think that those types of shared savings models or bundled payment models are really the best way to drive health improvements, both in quality and outcomes, health status, to really bring together all of the members of the team and really hold accountable all the members of the team for improving the health of a population, engaging folks where they are prepared to be engaged to manage their health, and providing them with the resources and tools that they need in order to make those decisions and to take the steps to engage their health. And so we're very excited, and we've been talking with the Center for Innovation about some of the things that they're going to be doing. We are very excited, again, about the ACO or shared savings programs, and we've been looking very closely at how we can help design and develop some of those payment models and how we fit into those.
I will add to that also that there's a group within the collaborative that is focused on reimbursement reform, and they do a weekly conference call, or pretty much most weeks, I think. So anybody who's interested in getting more involved in that, if you just check out our website, you should be able to find a link with times and dial-in information for that particular group. It's a task force working on reimbursement reform. There's another question here that sort of relates back to the patient engagement question, and that is, how can we guarantee patient engagement if the patient's not willing? Of course, the patient's behavior change and clinical outcomes, as well as physician's performance and financial goals, depend on it. Let me offer a quick thought there that's a non-technology answer, and then ask you if you've got any thoughts from an HIT perspective, Tracy. Actually, one of the white papers in our resource guide focuses on motivational interviewing, and as many folks on the call are probably familiar, that's a technique that comes out of behavioral health management, and of course it was originally designed for much more challenging and complex patients with significant behavioral issues, but there are some approaches to motivational interviewing that are probably more appropriate in a typical primary care setting, and there are ways to do it that I think folks who have done it have found can be very helpful in terms of getting better patient activation in their own care management. So I think that's, and that bottom line is that's a very non-technological answer. Where you can build the technology in is within the framework of an EHR. You can use something like the brief action planning tool that's actually built into the care plan, I think, which can sort of help facilitate and make it easier for the provider to use motivational techniques. But bottom line is that particular approach is not a particularly technological approach. But Tracy, have you got any thoughts in terms of a technology angle on that question?
Well, let me first say that I share the view that motivational interviewing and health coaching are very important components of patient engagement, successful patient engagement, as we found increasingly in the last 3 to 5 years, as many of these, the science behind this has really continued to evolve. I think that from a technological perspective, again, just as there's no one methodology that is appropriate for evaluating outcomes for every population health management program, there's no one intervention strategy or health information technology component that is going to be the right fit for every individual patient to successfully engage that patient. Some people will be very excited about using their cell phones. And surprisingly, some of our members are finding that particularly elderly populations are very receptive to using their cell phones and using their computers as well for contact and communication with their various providers. And so there are going to be an increasing number of intervention opportunities on the HIT perspective that will allow us to engage various segments of the population. But it does come down to what the individual feels most comfortable with, because you're already asking them to take control of their health and to make some changes in their health behaviors. You need to make sure that they're comfortable with how they're being asked to do that and how they're going to do that going forward. And so sometimes that's going to involve some sort of technology and sometimes it's not.
Next question is about stratification. And can you talk a little bit more about stratification methodology and HIT that supports it? Are there smaller scale products appropriate for small primary care practices or just at the higher ACO level?
Well, stratification will depend on, obviously, the goals of the program, the needs of the individual population, and the services that the entity, the practice, et cetera, can offer. Yes, I think there are a variety of stratification tools that are available for various practice sizes and patient population sizes. It's not something that I think is restricted to only very large populations. We've seen examples in physician practice models where stratification programs and technologies have been used successfully in smaller populations.
And I will, for folks who are just sort of looking at what's out there, one of the things I might suggest is to take a look at the Clinical Group Work Collaborative. Those folks participate in PCPCC and include a number of smaller vendors who are looking to find sort of plug-and-play solutions that can talk to each other that, while certainly work fine at larger level organizations, would also be appropriate for smaller primary care practices. So that's just one potential place to go looking for, not just for tools like this, but for any sort of HIT.
I would completely agree with that. I think what some of the work that the Clinical Group Work Collaborative is doing is very important, particularly when viewed from an individual physician group practice perspective.
Yeah, the world for 1 and 2 provider practices is so different from the big world that it's really important to have guys out there who are thinking about it from that perspective, and the clinical group work guys definitely are.
Yeah.
Next question here. It appears that your definition of population health management is used to develop customized medical interventions at the individual level you address interventions for entire populations, example, at the community or panel level?
Sure. Thanks for the question. Yes, we are looking at the ultimate end user, the consumer or patient. But all of these programs start with looking at the population to determine what the population needs are and what are the core demographics of the population. And that goes back to the question about stratification and identification that we discussed just a few minutes ago. I think that you start at the top level, as we have here with the framework. What is the region that you're starting with, and then moving down to through the population to the needs of the individual, and that's part of each stage of the process. When you're talking about enrolling and engaging, you're moving from that broad population approach with a broad understanding of what the population demographics and needs might be, to moving into discussions with individual consumers and patients to understand what might be holding them back from making some of these behavior changes in their health, and how you might best communicate with them, whether it's the physician directly or a member of the healthcare team, what type of intervention modality or communication structure is going to work best for that patient. So it continues to funnel down from that broader population level as you're getting down to the individual consumers or patients.
Okay, there's a question here. I'm going to try and reinterpret it. The question actually is, how can you get patients to buy into a model such as this if they generally operate from a paternalistic view of medicine? Any helpful hints? Wondering whether that was patients or physicians, because the question could actually go either way. Let's if I assume for a second that it's not a typo and that the actual question was patients, let me just offer a quick thought, Tracy, and that is, this I think goes to the whole issue of shared decision making, and I'll just throw out a little bit of data that I have from talking with some physicians who are very much involved in shared decision making, and that is, in their experience, a very high percentage of patients are actually really prefer not to be involved in paternalistic medicine, but prefer much more to actually be involved in their care process and in the decision making. So based on the data that I've seen from talking with folks, I actually don't see that to be a huge problem. The bigger issue is more the challenge of certain specific patients that just have a hard time getting motivated to do what they need to do. But let me toss it over to you, Tracy, and see if you have any different perspective on that.
I actually don't have a different perspective. I think you're spot on, and it certainly aligns with some of the research that we've seen and conducted here as well. I think you need to take into account, in addition to the individual in many cases, the family members and the caregivers. And sometimes it's the family members or the caregivers who are the ones who are most motivated, and sometimes that carries over to the patient and sometimes it doesn't. But there is generally, in the research that we have seen and in the surveys we've conducted with our own members, that there is a good deal of opportunity to engage the individuals, and they are very interested in learning more, and particularly through the concept of shared decision making. There's an incredible amount of interest in better understanding their options for treatment, particularly with chronic condition management as well.
There's definitely some really good data out there that suggests a couple of things about patient engagement in decision-making processes and in the care process in general. One is that generally patients have far less information than they really need to have to make good choices. And the other is that physicians understand what's really important to patients and how patients prioritize things far less well than they think they do. There's several studies in both of those areas which just suggest that there's lots and lots of opportunity for better communication of both information and sort of values-based stuff.
Mm-hmm.
Next question here, does the team member that you're talking about need to be an employee of the practice, or will it likely be that they're consultants? I'm in a PCP's independent practice that has hired me to assist with getting diabetes education and medical nutrition therapy. How will billing be incorporated to cover the expenses of these ancillary staff?
Well, that's a couple of questions. The first question is, I think that there's no one model for how a practice or a healthcare delivery entity may incorporate these types of components for population health management. Some may have the capacity to these resources in-house. Many will not. And many will take a hybrid approach where they might have some health coaches full-time on staff, but they're going to outsource some of their health information technology, whether it's their stratification processes or some of their other communication processes as well. And I think that's probably the most likely scenario, that we'll see a hybrid approach where physicians and practices, based on their patient panel needs, will incorporate specific components full-time on staff, but will outsource others. With regard to the payment question, I think that's where we see the bundled payments or the shared saving payments as becoming very important opportunities, such that the provider group, the physician group, the accountable care organization, the PCMH, whatever you want to call it in each situation, will receive the payment, but will then provide reimbursement for services that they've outsourced for the management and improved health outcomes of the various components of their patient panel.
And there was a related comment by the original asker of that question, saying, as a consultant, I don't have access to their EMR. I think the implication being, that obviously provides some challenges. And in your experience, is it normal that a consultant doesn't have access to the EMR, and how do you wrestle with that situation?
Well, it depends on how the care team is structured. Certainly some of our members working with physician groups and with hospitals and with other entities have access to the information necessary for the patients that they are going to be supporting and intervening with. And that hasn't been a problem. And that will, again, depend on how the care team is structured and how the responsibilities, particularly those as outlined in the PHM process framework, are meted out among the members of that care team.
And we're running down on the clock. Let's do a couple of more questions here and a few closing housekeeping remarks. And to those of you who don't have your questions answered, if you want to have further conversation with Tracy, I'm sure that that can be arranged by email. I'll apologize. We actually, this is the highest attendance we've had on one of our webinars so far. We had over 300 people register, and at one point about 140 were actually on the line here. So it makes it tough to get all the questions in when we have this many, but we're happy that that it's been as successful as it has. But let's pick a couple more here. Will Care Continuum be moving to get mobile health solutions covered by CPT codes so that physicians can get paid for using them?
I'm sorry, can you repeat that question?
Sure, yeah. Will you guys at Care Continuum be pushing to get mobile health solutions covered by CPT codes so that physicians can get paid for using them?
Well, it's not currently on our radar as a specific, well, it's on the radar, but it's not currently on our agenda as a specific action item, no.
And the population and the PCP offices aren't used to using electronic technologies to communicate with each other. Are there plans by any organization to expose them to technology? I think this is sort of really an adoption issue, right? How do you get folks who aren't used to using certain technologies up to speed and on board faster rather than slower?
Right. Great question. I don't think that we have an answer to that. I know I don't personally have an answer to it, but I think, again, many of the federal initiatives that I referenced earlier, I think, are working in that area. Particularly some of the regional extension centers are working to help physicians understand and understand the use and availability of these resources. And then other organizations that we've mentioned, including the Clinical Grouper Collaborative, are also looking to position themselves to help make these technologies more available and accessible to physicians as well.
All right. Well, Tracy, thanks so much for taking your time and for sharing where you guys are headed with this today. And again, I apologize to those of you who we didn't have time to get to your questions, but I think Warren can capture those questions and make sure that Tracy's got them so that we can certainly make an effort to answer your questions by email.
If I could, John, anyone who didn't have their question answered and who would like to is welcome to email me directly. My email address is tmoorhead, that's TMOORHEAD, @carecontinuum.org.
That's wonderful, Tracy. Thanks so much for offering to do that. And for those of you who might be attending for the first time, this webinar is actually part of a regular series put on by the PCPCC Center for eHealth Information Adoption. We normally do one of these a month. It's on the second Thursday in this time slot. And as you might expect, given the center, the topics focus on the use of health IT in the patient-centered medical home and the transformation of primary care. Just as a plug for our next webinar, it'll be on December 9th, and it will be kind of a special replay of the HIT panel from the October 21st stakeholders meeting. That was the one that actually got rained out by a fire alarm. It was the last one of the day, and we didn't have too many people by the time we got back into the building. So quite a few people asked if we could do a rerun. So we will be doing that on December 9th. It'll actually run 90 minutes to get plenty of interactive Q&A. And there are several panelists. Craig Brammer, who's Deputy Director at ONC, is going to be speaking on the Beacon program. Doug Arnold is Executive Director of a Connecticut-based physician association and is also actively involved in the Connecticut REC. And Sean Lyon is a nurse practitioner and one of 3 partners in what I believe is the first nurse practitioner-led patient-centered medical home to achieve NCQA Level 3 recognition. So those 3 guys were great in D.C. in October, and they're all going to be on again on December 9th in the same time slot. Also, you can find documents for this and all of our prior webinars on the webinars and podcast page. You can link to that off of the homepage. If you go to the PCPCC homepage, look in the lower left under resources. One of the options to link is webinars and podcasts, and you'll find all the prior webinars there with both audio and the file material, typically either PDF or PowerPoint. As far as the Center for eHealth Information Adoption, we do have a couple of new publications that you can find off the front page of the collaborative homepage. And anybody who's interested in what's up for the next 12 months or so, we've got several things going on. We have some ongoing work around meaningful use. That's being spearheaded by Bill Rollo. We also have a new initiative led by Jim Crawford that is looking at putting together a collection of papers on the role of HIT in the accountable care environment. And then we've got another team that I'm working with that's looking at opportunities to improve EHR usability to better support the PCMH. So if you're interested in participating in any of those, you can, off the center page, you can find contact information for the 3 of us, and feel free to give any of us a shout, and we'd be happy to include you in those activities. I think that's it as far as housekeeping. Again, Tracy, thank you so much for being here today to share your thoughts with us. And for all of you who joined us, thank you very much as well. We look forward to seeing you in December.